So I'm Angela Keene. I'm from Honolulu, Hawaii. I'm going to be 57 years old in a couple of weeks. I can't believe it's been 5 years since I got COVID. I got COVID March 6th, 2020. That was before the vax, before the state shut down. I contracted it on 6 days prior. I was a wedding officiant and I was officiating a wedding, and the couple was from Australia. And the best man was coughing and sneezing and had a hanky, and we shared a microphone. And exactly 6 days later, I came down with a fever, malaise, and that resulted in 8 weeks of being sick with COVID. I have a bit of a medical background. I'm not a provider. I'm not licensed. Um, I was a medical news journalist for many years with Hawaii News Now, KGMB News. So I do know a lot about medicine, have worked in clinical care since I left the news, very familiar, with medical terminology. So I had been watching the whole COVID thing unravel overseas. I had some concerns, but I didn't think I was going to get it. I was immunocompromised. I was on Cosentyx at the time for ankylosing spondylitis. And I would say I was sick for 8 weeks. I decided to ambulate at home. That was a decision made between my PCP and myself. She was very supportive. I had oxygen. I had a CPAP. I had all the medications. I had nebulizers. So I had the tools that an average person wouldn't have. I was very fortunate. I had extreme lung issues. I had the fogginess and the depression and all the things that you hear about from long COVID patients. By the end of the 7th week, I complained that I was still gurgling and had lots of issues with my lungs. We had tried many different antibiotics and many different treatments, and nothing really seemed to work. And I had requested dexamethasone because I knew that that was something that was being used. So I requested dexamethasone. I went into the clinic for an injection, and subsequently, within 72 hours, I started to clear up. That dexamethasone made me feel like a superhero. So I started to get back on track. I started to work in some of the volunteer efforts that I was doing for COVID initiatives, masking mandates, all different kinds of things. I was working with a team of people. I had some projects that I was working on with the Department of Health with the vaccine. And I thought that I could just full steam ahead and I was going to be fine. But I think the first thing that hit me was post-exertional malaise. I had this burst of energy from the dexamethasone that made me feel good. And I found myself doing media reports, for the media regarding COVID. I would put all my makeup on, put all my nice clothes on, go downstairs from my condo, talk to the media. And as soon as and I had my, big brave face on. And as soon as I wrapped up and went upstairs, I would hit my bed and I would be there for days. And my husband would come in and say, "You never took off your eyelashes. You never took off your makeup. Your clothes are still on. Are you okay?" I just couldn't move because I was so exhausted. And so then became this little dance with post-exertional malaise. I would feel better. I would do some projects, and then I would collapse again. I dabbled in some non-conventional things to help me get well. Everything from herbs and peptides for the immune system to, whatever I could get my hands on that I could find to help get myself better. There were things like miracetin, which is a flavonoid, which can give you stamina and energy. I just allowed myself to rest a lot. There was a point when I thought that I could go back to work and I thought that I was going to be able to do it. And I found myself working 8 to 16-hour days up to 16-hour days most of the time, because I couldn't remember anything. I would put things in one place and then look for files and then and I was working with physicians. They were very patient with me. But at the end of a couple of weeks, I realized that it was not something that I could do because I was so exhausted from trying to keep up to remember things, from trying to keep up the pace with everyone else. I would overheat, I would get exhausted, and then I would collapse again. So weekends and holidays were spent, in bed resting, sometimes 72 hours. I would have insomnia, and then I would have hypersomnia. And I think that this is a condition that's very similar to chronic fatigue syndrome, Lyme disease, fibromyalgia, those types of conditions that we used to know about in the 80s and 90s that not everyone took seriously, but some physicians took the bull by the horns and took care of their patients and listened to them. So, you know, I think patients will knock on many doors to find out what works best for them and which physicians are compassionate enough to take the time and listen to them. Some of the things that I found are electrolytes can be an issue, not enough sodium because dysautonomia, POTS, you know, all the different kinds of things that can play into this can all be part of the post-exertional malaise, along with just the attitude of feeling better and then overdoing it. So things like watching blood pressure, watching glucose levels, getting tested for dysautonomia and POTS, watching, you know, heart rate and blood pressure and all those different types of things that are really important in tracking a patient like me who comes in with complaints, trying to figure out what's going on. And I think some of the best advice is rest when you feel it, rest, and don't push yourself, don't overdo it. Have lots of blood labs done, talk to your doctor, keep in contact with them. And, you know, sometimes those blood labs can be kind of disappointing for us because we can come in with all these symptoms and physicians can do all the blood labs under the sun, and the blood labs can come back quite normal. You know, some folks like me end up in the emergency room with exhaustion and heart palpitations and all different kinds of things going on, and they put an IV bag up and put us in a bed, and within a couple of hours, everything goes back to normal, and they send us home, and it's kind of like, now what do I do? Now, does this repeat itself? Yes, I've been in the ER many times in the last couple of years just because of these types of episodes. So, so I think my message to physicians is have patience with your patients, listen to them. I get calls and emails from all over the world from long COVID patients. I think the first thing that they tell me when I listen to them is that I feel like I've been heard. And that's probably the first sentence that I hear that comes out of their mouth with a lot of emotion. I don't think there's a one size fits all for these patients like me. I think it takes a combination of things to help them get well. I think that, so I work for a brain specialty clinic, so I'll show you something here. Let's go to a photo if they have it. You can see my before and after, and you can see me in the throes of COVID. So on your left, that was me in the middle of the night recording a message to my mom because I was afraid I was not going to live through the night. I couldn't breathe. I couldn't think. I had severe depression. I had post-exertional malaise to beyond belief. Then there was a point when I took the bull by the horns and said, okay, I need to eat healthy. I need to get my A1C under control. I lost 52 pounds. I did the OMAD, so I did fasting. I used different types of alternative treatments like the flavonoids I was telling you about, watching my blood sugar, watching my electrolytes and those types of things. And then we'll go to a second picture here. And this is something for the clinicians to be able to see. This is I'm going to have them pull up a brain map of an EEG. So when the EEG comes up, you'll see it here. And it's a little hard to see because it's a little small. But on the left is the first EEG that I had, and this was done at Brain Health Hawaii. This is a cumulative EEG. It takes about 5 minutes. It's wireless. If you look at the blue, on the top, you'll see blue, and then you'll see green, and then you'll see teal, and then you'll see the yellows and the oranges and the reds. So think of this as the blue is the frontal lobe. And as you move down, those colors are shifting and changing. That's the middle of the brain. And then toward the yellows and oranges at the back of the brain. And the very last line is the heart. So that first, all of those lines, all of those, you know, lines that you see should line up like Mount Fuji, like perfect peaks from the top to the bottom. If you look at the first two lines, that is my frontal lobe. The odd numbers are the left side of the brain, the even numbers are the right side of the brain. And my frontal lobe was basically stunned. This is what you would see when you go, when you might see a patient that has been in a car accident or has had a TBI or a severe concussion. So what happens is, the neurons sort of get injured and they either become hyperactive with arrhythmia, or they will go to sleep and there will be no activity. Other parts of the brain take over, but they don't do a very good job. So you'll get all this different symptoms of people having memory problems and brain fog and exhaustion and tiredness and depression. And so for me, my frontal lobe was not even working. Now, flash forward on the right after treatment. So I was doing transcranial magnetic stimulation. I had failed 6 medications, psych medications for severe major depressive disorder, hypersomnia, insomnia, ADHD-like symptoms. I was basically in a state of pre-dementia for a 50-something-year-old woman. So as I was going through these treatments, and this, by the way, was paid for by my insurance because I had failed quite a few medications. And the treatment protocol is 40 treatments. You go 15 minutes every day for 40 days during the week, Monday through Friday. As this was happening, I began to have a bit of an awakening, and you can see that on the EEG. So you can see those perfect peaks happening. This is probably one of the best cumulative EEGs that I have there on the right with the arrow. And you can see that the lines, the peaks are starting to form once again. When that started to lift, a lot of my post-exertional malaise and my symptoms started to dissipate. I was able to pay attention. I was able to hear conversations. My depression went away. Now, is this the end all be all? No, there's lots of different modalities out there. But what I can tell you from a patient perspective and someone who knows something about medicine is many months down the road, about a year later, I did catch COVID again. I was vaccinated. I was triple vaxxed, and I got it from my mother-in-law. And I thought that I was going to be okay because I felt pretty good. I was sick for 10 days. I had Paxlovid as well. I had rebound COVID. But again, the post-exertional malaise kicked in again. I went back to clinic and I had another EEG, and all the staff came pouring into my room after my EEG, and their mouths were wide open. And it was a clear sign, again, that my frontal lobe was once again hit. Clinically, that was like, wow, this is real. It really affects my frontal lobe. I once again went through treatment and ended up with those beautiful peaks showing back up again, and was able to take control of my life and prevent, some of the things from happening with the post-exertional malaise. Since this time, it is now flash forward 5 years later. I'm doing pretty good. I have been at about 90 to 95%. I had a respiratory infection earlier this year, and that kicked off dysautonomia and POTS, and I now have post-exertional malaise associated with this. So my blood pressure is dropping around 74 to 58 some days, most days. I do sodium loading, I do electrolyte loading. And usually by about 4:30 or 5 o'clock, my body has been going through a marathon and I start to slow down and I start to crash and the post-exertional malaise kicks in. So that is something that I'm dealing with right now. I'm waiting to see a neurologist for this and hoping that we can get on top of it and hopefully get some medications to help me get through that. But again, I'm very aware of when it happens. I try to do as many preventative measures as I can. But it happens, so I have to submit to it, rest, and then start over the next day. I'm very lucky that I have a great employer. I have a great team of people that I work with. I have great physician friends that I can call on once in a while for assistance or just for an ear. But I can tell you it's very real, and it happens. And I'm proof that patients can overcome it with determination and finding the right modalities and finding the right physicians to communicate with and to work with. Hopefully I didn't go over time.
No, that was perfect. Thank you so much. And so now we're going to go ahead and move on to Dr. Bateman. She can come on and give her presentation.
Okay, let me share. Can you see my presentation okay?
Yes, perfect. Thank you.
Okay. So thank you very much for a chance to come and talk to you today. I'm going to focus on post-exertional malaise, and there's so much to talk about with long COVID, but I'd like to explain a little bit about it because it's a concept that a lot of people don't understand very well. You already read the conflict of interest and you saw the objectives. Essentially, I want everyone to be able to recognize what causes post-exertional malaise, why it matters, and what to do about it. So the best we can at this point. So post-exertional malaise is worsening of the patient's symptoms and a further reduction in functioning after any given stressor, physical, cognitive, orthostatic, emotional, sensory, and it varies from person to person. And it's really diagnostic in ME/CFS, which is myalgic encephalomyelitis chronic fatigue syndrome, which is generally considered a post-infectious syndrome, but at least a complex chronic illness. And we've come to understand that a subset of long COVID meet ME/CFS criteria and thus also have the kind of PEM that people with ME/CFS have. It's really, post-exertional malaise is not fatigue. It's not the same as other chronic illness fatigue. It's not just deconditioning. It's not just exercise intolerance. It's not the same as exercise intolerance in a number of other chronic illnesses, may have some similarities. And it's not the normal or known consequences of excess physical activity. We all know that you can have symptoms after excess exertion. Just a little background on this, because I think it might give you some insights. The phenomenon was first described in the 1950s when the first case definition of myalgic encephalomyelitis came out, because Dr. Ramsey was studying post-infection outbreaks, and he gave it that term, myalgic encephalomyelitis. But the term post-exertional malaise is first found in the 1994 International Research Case Definition for Chronic Fatigue Syndrome. It's sometimes called the Fukuda criteria. But it was problematic because post-exertional malaise, when not a required symptom, you only had to have 4 of the 8 minor symptoms to meet the diagnosis. And also the earlier case definition in 1988 called the Holmes criteria kind of described it as prolonged generalized fatigue after levels of exercise that would have been previously tolerated. But both of these case definitions really didn't understand that the core illness we call ME/CFS required post-exertional malaise as a predominant symptom. There's a case definition called the Canadian Consensus Criteria of ME/CFS, which was published in 2003. It was a group of ME/CFS clinicians that came together and created a clinical case definition. And this was the first case definition to require post-exertional malaise for the diagnosis of ME/CFS. There was a revision of this called the International Consensus Criteria, the ICC, that were published in 2011 that really wanted to clarify post-exertional malaise and also try to refine the Canadian Consensus Criteria. But I want to show you these international consensus criteria. These are used all over the world, except in the United States. And they sought to clarify the term by using a different term called PENI, or post-exertional neuroimmune exhaustion. And the reason I want to talk about this is the definition of PENI is a really good description of post-exertional malaise. So it's a pathologic inability to produce sufficient energy on demand. And the prominent symptoms are primarily in the neuroimmune regions. And then they have these 5 characteristics. So marked, rapid physical or cognitive fatigability, post-exertional symptom exacerbation, and so almost any symptom of the illness, and there are many, can be flared or amplified in post-exertional malaise, post-exertional exhaustion, and the recovery period is usually prolonged. If it's true post-exertional malaise, usually longer than 24 hours to recover. Of course, it depends on how severe the stressor is. And then there's a low threshold of physical and mental fatigability and a substantial reduction in pre-illness activity level when you're in post-exertional malaise. So really, I just wanted to paint that picture for you with this case definition. But in the US, we use the Institute of Medicine ME/CFS clinical diagnostic criteria that were published, based on an evidence-based review that were published in 2015. So these are ME/CFS, not long COVID. But I want to talk about how long COVID is related to ME/CFS as they share post-exertional malaise. And if a long COVID patient meets these criteria, they have long COVID associated ME/CFS as the cause of their ME/CFS. So the major criteria that must be moderate to severe and present at least 50% of the time, these aren't fleeting symptoms, are the first two are really important: impairment of normal function and post-exertional malaise. And these go hand in hand, because if you exceed your functional capacity, it causes post-exertional malaise and goes back and forth. Then patients have to have unrefreshing sleep or some kind of disordered sleep, and at least one of the following: cognitive impairment or orthostatic intolerance that is really based on autonomic nervous system dysfunction. Now, these are evidence-based. The hope is that we'll get better at doing this diagnosis and getting more diagnostic tests. But if you use these criteria, if you know how to use them and apply them correctly, they really do identify people who meet these criteria. It's important to remember, though, that people with ME/CFS and long COVID ME/CFS can have many other symptoms. So chronic pain, all kinds, immune and inflammatory manifestations, infection manifestations, and especially important are neuroendocrine manifestations. So myalgic encephalomyelitis is distinguished from other types of illness fatigue by the degree of impairment and debilitation and the development of post-exertional malaise, along with those other symptoms. But these are the key ones. These are the most important things to be able to screen when you talk to patients. And so post-exertional malaise is illness symptom worsening or relapse triggered by otherwise minor activity. And activity can be, doesn't have to be exercise. It can be physical, cognitive work, orthostatic stress, sensory overload, emotional stressors, and all kinds of stressors. And this varies a little bit from person to person. So as I said, this can occur in many patients with long COVID. The other thing to understand is that the functional capacity of people with ME/CFS and long COVID ME/CFS has a broad range, from mild impairment and difficulty sustaining a normal schedule of work, school, or family, and low tolerance for exercise, all the way over to patients who are completely bedridden. There are patients who can't stand light and sound, and they're barely able to speak or move with really, really severe symptoms. So I just wanted to throw this in here because this term is used in the literature. Early in the long COVID pandemic, when the rehabilitation community started talking about post-exertional malaise, they used the term post-exertional symptom exacerbation, or PESE. Remember, that was one of the features of the international criteria for PENI. So you can watch for that term PESE as well, post-exertional symptom exacerbation, especially in the rehab literature. So why does it matter? I mean, why do you have to recognize this? And the really is, and I think you heard this in our patient representative today, that exacerbation of illness. So when you put yourself into relapse symptoms of PEM, it can delay recovery or cause your illness to have a worse trajectory. I've seen people who kept pushing and pushing and ended up completely bedridden from this illness. So preventing post-exertional malaise improves symptoms, the ability to function, and prognosis. This is totally clear in ME/CFS. Remember that long COVID, the case definition of long COVID, is a very big group of people, some who have minor symptoms and some who are going to get better faster. But if long COVID patients meet ME/CFS criteria, they have to be a lot more careful about dealing with post-exertional malaise. So I don't want to spend too long on this slide, but do we know from research that staying within your energy envelope and avoiding post-exertional malaise is positive, and does it really make a difference in the illness? So I'm going to show you just some of the figures from this study that was done in 2009, where they took 114 ME/CFS patients and they trained them twice a month for several weeks, 6 weeks, a trained nurse therapist to teach them how to pace their activity. And if they were able to do it and stick to it, they had a completely different outcome than the patients who were not successful at pacing their activity. And on the bottom here, I wanted to tell you that the NIH funded Recover Energize study, which is we finished enrolling part of it, and the other half of it is still enrolling. But the Appendix B is really trying to see if pacing impacts the prognosis and the symptoms of people with long COVID and post-exertional malaise. So back to this 2009 study and this is a publication from 2013. On the left, you can see, and the solid line is the people who learned to stay within their energy envelope and not trigger PEM. You can see that at baseline, post-testing, so 3 months and 6 months and 12-month follow-up, their physical function scores got better and better, as opposed to the patients who weren't able to pace and stayed about the same level. And the reverse is true about the severity of their fatigue. So as time passed and they kept pacing their activity, their fatigue scores came down and down. So even with this small study, they were able to demonstrate that pacing or staying inside your energy capacity is likely to improve prognosis. So, what is pacing? I just want to kind of describe what pacing is, because it's hard to do, actually. And so if we kind of go through these boxes, pacing is assessing your energy capacity and then prioritizing activities to just do the most necessary things to prevent post-exertional malaise. And sometimes you have to do separate short activities throughout the day with rest periods in between. And I usually encourage people, when they're resting in between activities, is to engage in recovery behaviors. That would mean lying down, hydrating, putting your feet up, doing some things that will, closing your eyes, making it quiet, even if it's only for 15 minutes, many times during the day. In general, you've got to avoid significant energy debt, because the worse it gets, the harder it is to repay it. The sicker you get and the longer it takes to recover. And I usually use that analogy of debt like a credit card. So you really don't want to accumulate a big amount of debt. You want to, you can get a little bit and then repay it immediately and try to keep up with that. Another important thing is to mostly be in a preventive mode. You really want to prevent frequent and severe post-exertional malaise, not just try to get better from it once it happens. I mean, it's inevitable that you'll make mistakes. But you want to develop a pattern that avoids ongoing push-crash cycles as much as possible. There are people who push, crash, and get lower and lower and sometimes don't recover for very long periods because of what happens. This was a study done by some NIH researchers. This was ME/CFS, not long COVID, but this was part of an inpatient study of ME/CFS at the NIH. And they asked the patients to describe what happened when they were in post-exertional malaise. And this is called a word cloud. And what it does is it puts up all the symptoms and ranks them, right, by size and color and the center of this word cloud. So post-exertional malaise is characterized by exhaustion, cognitive impairment, often muscle aches and pains, sensitivities, difficulty. You could just read those yourself. There are many, many, many symptoms, and they're not exactly the same in everybody, but those key symptoms are the feature of post-exertional malaise. You feel very sick, really sick, not just tired, when you're in post-exertional malaise, and it's worse depending on the severity. This is another study. This was done by our group. We had 150 ME/CFS patients who were enrolled in research. Again, this was pre-COVID. And 75 had been sick more than 10 years, and 75 had only been sick for less than 4 years. But we asked them this was part of an NIH-funded study, but we asked them open-ended questions about their post-exertional malaise. And I want to show you what they said. So on the A are the triggers, how they ranked the triggers for PEM. And you can see in the light blue, even low physical activity, then medium physical activity for some, and it took high physical activity for some. Sometimes only a low cognitive trigger, sometimes medium, sometimes high, stress. But look at these triggers, right, that are likely to contribute to relapse of symptoms and cause PEM. The second one is really, what does it feel like to have PEM? This was in our study. And you can see around here, there are a lot of general symptoms. We had to lump them. These were open-ended questions, so we lumped them in categories. But sleep is disturbed. There can be musculoskeletal pain, flu-like symptoms, sometimes respiratory, a lot of neurologic symptoms, GI, more POTS and orthostatic dysautonomia. So that's the experience, the trigger and experience in our patients. What did they do about it? What did our patients say they did about it? And I want to make the point, as I did before, the treatment and management of PEM is really preventive and rests on structured pacing. And this has been true in long COVID. And I put a reference down there to a long COVID study assessing how important it was to pace and avoid post-exertional symptom exacerbation. And I want to make the point that supportive and symptomatic treatments after PEM occurs aren't very helpful. I was trying to talk to NIH researchers about PEM, and I said it's kind of like getting a sunburn. And I'm a fair-haired person, right? And the severity of the sunburn depends a lot on the exposure. But the recovery, really, you can't help it with anything, depending on how severe it is. You just have to let yourself heal and gradually recover from that insult. So in our study of those 150 patients, we asked them, what do you do to recover from post-exertional malaise? And you can see that by far, the majority of patients say they just have to rest and sleep and hydrate and try to eat well and treat symptoms and try to cope with it and try to reduce their stressors. They just have to wait until they get better. And then D is, what do you do to prevent post-exertional malaise? And you can see that by far, 2/3 of the patients were pacing and avoiding the things that triggered PEM, being aware, following a healthy lifestyle. And this is really a critical statement about how we have to take post-exertional malaise very seriously and learn how to pace activity. And as medical providers, we need to identify and coach patients about how to do this so they have a more stable course. So what can you do to help ask people about PEM? And these are really framed for medical providers, but you know what, if you're a patient, you can also use these same things to decide if you have post-exertional malaise. So the most important question is, what happens when you try to increase your activity, eventually, especially? And does it cause you to have push-crash cycles? And our post-exertional symptoms kind of flu-like, weird, not just like being tired, but you feel sick, widespread pain, more brain fog, disturbed sleep. And are these symptoms kind of unusually long? Like, you do a workout when you're well and you might be sore the next day, but, pretty much it works itself out in 36 or 48 hours or even less. And this is a really unusual thing. Are the consequences of activity unusually delayed from the activity? So I think if this is the debt again, let's say you can get $100 debt on your credit card and you go $10 in debt every day. Well, by the time you've done that for 10 days, you're over your limit and you go into PEM. And you may not think that the activity you did on any given day was enough. On the other hand, you can do one big, long, horrible, sustained activity and trigger a relapse as well. And do the symptoms result in lower activity tolerance? So these are just examples of questions that you might want to put in your back pocket about how to talk to people who have PEM. For those that are interested, there is a diagnostic tool called the DePaul Symptom Questionnaire, or DSQ-PEM. You can find it easily if you Google DSQ-PEM. And this asks patients, this is really an older tool, and it was used to decide how to enroll people in ME/CFS research. But we're using it in our recover studies for long COVID as well. So they ask these 5 questions about the frequency and severity of illness. and you can kind of read through those your own and on your own and how you score. And then you ask, do you experience a worse fatigue energy related illness after engaging in minimal physical effort, or do you experience a worsening of your illness, you engage in mental effort? And it has to be one of those. And it really needs to be longer than 24 hours or 14 hours duration. So here's kind of the key. If any symptom up here has a score of 2 or more in frequency and 2 or more in severity, those are positive. And then you have to have either worsening of it has to be triggered by physical effort or mental effort. And really the symptoms have to last 14 hours or more, because normal exertion would resolve sooner. So if someone wants to use a tool or to kind of confirm diagnosis, you can use the DePulse symptom questionnaire. I prefer just taking a history myself, and asking the patient questions and communicating. So, I can't talk in this setting about the mechanisms and physiology of PEM, because honestly, it's not clearly known. I mean, we know a lot of things, but it's a major challenge to understand it. And there are many studies that show pathophysiologic changes, especially after exercise, orthostatic, or cognitive challenge. But we still don't understand it totally. But we know it involves the nervous system, particularly the central and peripheral nervous system. So what happens up in the brain, as we've heard, and what happens with your autonomic nervous system, controlling circulation and perfusion. And then there's an element of chronic immune dysregulation we're really trying to understand, and probably abnormal cellular metabolism or some kind of altered mitochondrial function within the cell. And this is holding true in long COVID research, as well as what we've learned about ME/CFS. So just a word, so we have time for the case and talking about some more things. What is my advice about exercise and fitness? And you can kind of extrapolate this to other things, but people really want to exercise. And some people can't exercise at all. I mean, they can barely do activities on a consistent basis. And what you hope to do is create a consistent day-to-day level of function, even if that's overall lower. And people learn this the hard way when they have the illness, right? They go through these phases of doing and doing and doing and crashing and staying down for days or weeks, and then feeling better and going back. But you just want to try to get away from that push crash cycle. So if people are able to exercise or want to start exercising, I usually tell them to do very short, gentle sessions, even if it's 5 minutes of slow walking. And then maybe do that on Monday, and then observe on Tuesday. And then if you had no consequences, try it again on Wednesday, observe on Thursday. And if you get post-exertional malaise, you need to backtrack and not do it. So being able to sustain an activity without PEM, if that's focused on exercise, is very important. People do better in water. And people do better if you focus more on flexibility and strength and less on cardio. Although really gentle cardio, like important life skills like walking, can often be used if you're careful. Some people keep their heart rate lower than the estimated heart rate at anaerobic threshold that they think helps them with this. But the most important thing is to allow a rest and observation day between attempts to increase fitness. So I wanted to tell you about this study. It's been a little controversial in the ME/CFS community, but last year there was a rehab publication that came out trying to address what to do about cardiopulmonary exercise training and physical therapy in long COVID. So they basically said, recognized post-exertional malaise and said there really is no consensus about optimal training strategies. So they proposed that that exercise procedures and physical therapy should be based on the presence of post-exertional malaise, whether it's mild or non-existent, mild or moderate, or severe, and really adapt any kind of attempts to rehab based on what people experience in terms of their activity tolerance, and to stratify these according to the presence and severity of PEM. If you're one of those people who can't tolerate much of any activity, then talking about exercise can feel really invalidating and frustrating. So some take-home messages I'd like you to think about. While we may not completely understand it, post-exertional malaise, exceeding the body's energy capacity results in illness worsening. And the severity and duration of post-exertional malaise are relative to the excess energy expenditure. Knowing what that is the big challenge, because it can happen from all kinds of physiologic stress, physical activity, orthostatic stress, cognitive work, emotional exchanges, infections can trigger it, poor sleep, sensory input, etc. And you have to add all of those up in using up your energy expenditure. And then here's the other frustration: the type, intensity, frequency, and duration of triggers or factors, and the threshold of triggering PEM varies day to day at stages of illness and from person to person. So when people are really sick, they may trigger PEM super easily. When they start to get better, that threshold for triggering PEM may go up. And it's just really hard to maintain a consistency. So the absence of primary treatment, in the absence of primary treatments for these diseases, honestly, the mainstay of treatment is pacing and preventing illness exacerbation, as well as identifying comorbid conditions and trying to treat them. And I firmly believe, after 30 years of taking care of ME/CFS patients, that the better you prevent PEM, the more likely you are to stabilize and improve. And the opposite is also true. And people who are sick can really make themselves very sick. Fortunately, many people with long COVID are still getting better within a window of their illness, and we don't really have good long-term data yet. So if you want to refer back to the PowerPoint, or there are at Bateman Horne Center, we have a rich number of resources on our website. We have training for physical therapists and occupational therapists. We have a PEM video series for clinicians. There are other great resources for understanding about pacing and learning how to manage. So I'm going to end there, and we'll come back to, wait a minute, I got to unshare. Stop share. There we go.
All right, wonderful. Thank you so much. We'll go ahead and jump straight into the case study while all that information is still fresh.
So if Melissa or can you be, oh, perfect. So while we get the presentation ready, so what I'm hearing from Dr. Bateman is that pacing is very important in trying to reserve your energy and to try to avoid getting the exertional malaise itself. And so do you advocate using any type of pacing, or there's all these devices that people use for heart rate variability, cerebral vascular flow. Do you try to keep people and help them with their pace points and things of that nature?
You know, there's many ways to do it. It's hard to do, right? And there's no tried and true way to do it. I like people to learn their own body and how their body responds, and understand when they're doing better and they have a little more energy, but to never forget there is going to be some place, right, where activity will trigger. I've seen people get almost all better and a year later trigger a relapse starting an exercise program. So you don't want to be scared to move, but you want to be really in tune with your body. I don't want to promote any apps in particular, but there is an app, I think it's in the case. There's an app called Visible, where you wear an armband and it helps you learn how to pace. You can manage your heart rate and try to understand what heart rate during exercise is more likely to trigger a relapse in you. But there's nothing tried and true yet. I also want to say real quickly that you can get that there are two different things. The mitochondrial dysfunction and the energy problem in the cells is a little different than triggering a relapse from orthostatic intolerance. So when things happen right while you're upright, you can get a lot of symptoms and feel really sick and have to lie down. That's the orthostatic intolerance triggering the symptoms. And if it's severe enough, it can cause delayed problems. But the problem about exceeding your energy envelope is it can build up on you, and it can kind of sneak up a few days later and last a long time, and it's much, much harder to monitor.
Thank you. I think that really helps out. And Melissa, if you make the next slide, I think some of this will be captured in the case, along with some questions about diet and about mast cell activation. So it's a 51-year-old female who has prediabetes, on Majuro, hypertension, and then sleep and migraine issues. Long COVID. The individual does have ME/CSF with post-exertional malaise episodes where there's fatigue. That's often triggered by travel, social events, and exertion. So both an emotional, a physical, as well as a mental, behavioral one also. So even pleasurable things, although if it overexerts, they could also lead to post-exertional malaise. So it's not only a physical for this client of ours. Patient uses a visible pacing app. Patient has tried Florinef, metformin, low dose naltrexone, modafinil. We even tried Valtrex and Celebrex. And then B12 and the oxaloacetate, which hit towards the mitochondrial issues, but they all didn't have any benefit to our client. Patient also has dysautonomia, very similar to what Angela had mentioned. Our client, because of the dysautonomia, is currently taking Mestelon and clonidine. Patient has hypertension, so it's kind of tricky in terms of kind of controlling the dysautonomia. She does use losartan and also mifepristone, more of a on needed basis. Does take salt to try to help, but again, it's a tricky given the hypertension, and does use tetostocking. The migraines, she uses Nurtec, B12, B12 as well as magnesium. And then in terms of cognitive brain fog, has a normal MoCA, but still working remotely, but has worsening of these effects. Thankfully, her employer also is very very caring and nice, and allows her to do at home work where she'll actually be able to lie down during the day. So that has been helpful. And respiratory has intermittent shortness of breath, but normal PFTs. Next slide. The recent course had some slight improvements, but then traveled to mainland and then had multiple episodes of PM, I think because of the stress of the travel, as well as possible dehydration and overexertion. Blood pressure was continued to be a issue. And then dysautonomia, you could all see that the Mestelon, clonidine, losartan, and nifedipine were all used to try to control the dysautonomia. And the person does have a cardiologist kind of helping manage some of these symptoms. You can see that the migraines, multiple medications, as well as respiratory, has multiple different types of inhalers. We learned from our speaker last week about using the respiratory inhalers, and I believe it's helped this client out also. And then finally, patients, because of the pre-diabetes with the Majuro supplements and some sleep, definitely some sleep issues. And so the final slide shows just the questions we asked. Is this her new normal? Is she completely intolerant? Given their intolerance to low-dose naltrexone, should we try to re-challenge? And then suggestions on her dysautonomia and lifestyle modifications, like in terms of diet and pacing. And so, Dr. Bateman, if you have any suggestions, let us know.
Yeah, let me make a couple of comments. I'm just going to answer your questions and give you a short answer, okay? And the first one is this her new normal, and will she be able to get back to her prior baseline? The answer is, I don't know. When patients have been sick, the longer people are sick, the harder it is to get completely better. I never say never. But the goal when people have been sick for more than a couple of years is really to achieve stability in symptoms, right? And be able to get back to as many life activities as possible while maintaining some kind of stability, even if that means working from home, et cetera. And so time will tell. I think LDN, I love LDN and I use it a lot. And sometimes, yeah, I would re-challenge. It's kind of subtle, it's in the background, but I think it helps a lot of people with long COVID. And you can start really low, like less than a milligram, half a milligram. I have people start on 1/10 of a milligram and just slowly build the dose up. The last two are the things I wanted to talk about the most with this, and that was what struck me about this case was really the first two parts, the problems. So you talked about, you know, her ME/CFS with PEM and her dysautonomia, then migraines, cognition, respiratory. And I'd like to just quickly say the migraines, cognition, and respiratory respond to supportive care, and they'll also respond to better management of the first two. So the biggest challenge in this case is having dysautonomia in combination with hypertension. And as you mentioned, I don't know the right answer and we have no guidance, but I will tell you what I do. And that is, I tend to not use any dysautonomia drugs that raise blood pressure. And I don't have them replace sodium. So we use fluids only and compression and kind of body position. And then you can usually use really low doses of antihypertensives. And I usually lean toward an ACE inhibitor or an ARB and sometimes low dose beta blockers. But I really avoid diuretics and avoid drugs that are strong peripheral vasodilators because I think it worsens the venous pooling. But you know, it's a tough one. And it's really easy to over-treat the hypertension, and then they have orthostatic hypotension, and it's really hard to know it's there unless you actually do a lean test. So I would usually, let me see, and there is something called orthostatic hypertension that we aren't aware of. We do so many lean tests that I can tell you some people can look perfectly normal and have a low blood pressure lying down. And when you stand them up and they have orthostatic stress and they get that sympathetic response, they become very hypertensive, especially if you're blocking their heart rate response. And it's sort of like if it can't raise their heart, then it raises their blood pressure. So we do stand tests. You need to do a full 10-minute stand test, and we do them to assess treatment. I even have patients do it at home midway through their doses and see how their hydration is doing it. And we tweak the meds according to how they respond. But I'll just say that's a super big challenge, especially in someone who is predisposed to hypertension with prediabetes and sleep apnea. So important challenge. I think in this case, learning how to pace activity to avoid PEM is probably one of the single most important interventions. So lifestyle modifications that I listed were really becoming expert at pacing to avoid PEM. And also, you know, I think maximizing her GLP-1 agonist and education to achieve weight loss, you know, do as much as possible to treat her metabolic syndrome because that is helpful. There's some evidence that those low doses of GLP-1s reduce the inflammation that may be causing POTS. So this could be a 2-hour talk. So since it's close to the end, I think I'll end there with some of my comments. And maybe I can send in a copy of some of my comments that might be helpful to you later.
Thank you so much. I'll just open it up to the audience just to ask questions.
So I'm not seeing any questions, but I do see Angela Keene stated that she's currently on the LDN and it has helped tremendously from the patient side of things.
David, did you have a question?
Yes, thank you, David Duroff. Thanks, Dr. Bateman. I'm just curious. It seems to me that there is, at least from where I sit, possible large overlap between ME/CFS and PEM and mitochondrial, or excuse me, mast cell activation syndrome. And I'm just wondering if you would comment about, sort of, I mean, I think obviously in the clear-cut cases where you meet all the criteria, that maybe that overlap isn't important, but I think for some patients, it might be a little bit confusing understanding whether you're, especially given the time lag between some of the antecedent events, and stress can certainly trigger MCAS and it can trigger PEM, and exercise, both of them, and many of the symptoms that people experience are the same. And I'm just wondering how you kind of deal with that.
Yes, thank you for that comment. It's super important. And I put myself some comments, and the first one was to explore mast cell activation syndrome as a comorbid condition, because they are intimately related. And the GLP-1 agonists can improve mast cell activation too. And there's a lot of regimens we use for mast cell activation, it's really important to look at that as a comorbid condition along with all the others. It's challenging. We have some good talks on mast cell activation, and there's some on YouTube and other places, but you can't depend entirely on testing, objective testing for mast cell. You really have to just try some things and see if it moderates symptoms. I've seen people's standing heart rate go from 140 to almost normal just by starting antihistamines. Early on. Antihistamine, H1 and H2 blockers are not the end all and be all, but we use a lot of mast cell stabilizers and other things in our clinic. So thank you so much for that comment.
Thank you.
All right. It looks like that's all we have for today. Thank you to all of our presenters today and everybody who joined us. Our next session is going to be on September 23rd, and the topic that day will be sleep abnormalities in long COVID. So we hope to see you there, and have a great rest of your day.
Thank you, Dr. Bateman.
Thank you for allowing
appreciate
me
it.
to come and share.